Hey, everybody, welcome to Resiliency Radio, your go-to podcast for the most cutting-edge insight in integrative and functional medicine. I'm your host, Dr. Jill, and with each episode, we dive into the heart of healing and personal transformation. Join us as we interview thought leaders, medical experts, researchers, and all types of interesting people to bring you tips and tricks for optimal performance, longevity, and just to live a better life of thriving in the midst of whatever you're facing. Today's no different. We're going to talk about weight loss and hormones, a topic in the minds of many of you, many of the listeners have really enjoyed. I've had some previous episodes. Today is going to be such a treat. You're going to love Dr. Melody Rodarte. Before I introduce her, let me just remind you, you can find curated, amazing products for your optimal health and performance at drjillhealth.com. That's DRJILL health.com. And I always love to grab one of my favorite products here just to randomly. This one is a bestseller, often on the market. It is, as far as we've run out of it before, it's called Needle-Free Serum. This one is kind of a Botox in a bottle for those of you who need a little help around the eyes or under the eyes. A little goes a long way. So this bottle will probably last you 3 to 6 months. You just need a couple drops. It's called Needle-Free Serum. It is one of our top sellers, and you can find it at drjillhealth.com. Okay, let me introduce Dr. Melody. Dr. Melody Rodarte has been a distinguished double board certified specialist in internal medicine and obesity medicine, and she served as a cornerstone of comprehensive healthcare in Arizona since 2006. She takes a personalized approach to help patients feel better, look better, and ultimately live better, centered around the forefront of how medicine, from mental health and otherwise, root cause medicine. She has multiple practitioners in her practice, and she brings such a wealth of knowledge in functional integrative medicine and root cause medicine. You will love this interview, so let's get to it. Dr. Melody, I am delighted to have you on the show, and it is one of the most popular topics. You've been doing this well before it was popular, but our title today is Hormone for Weight Loss, and I don't know if there's any more relevant topic to my audience because it's a lot of women 35 to 65 who are struggling with weight gain and what's going on with my hormones. So guys, if you're listening today, stay tuned. I know we're going to go deep and I know we're going to get some great information from Dr. Melody. But before we go there, I always love to know your background as far as how you got into what you're doing. I think you said obesity medicine was one of your backstories. Tell us a little bit about how you got into medicine and then the journey to what you're doing now.
Yeah, first, thank you so much for having me. Any opportunity to promote health and advocate wellness, I love to take. So I follow your podcast, so I'm super excited to be with you today. So thank you for this opportunity. I love wellness. From the very beginning, when I was an internal medicine resident, I noticed that if I could teach my patients how to eat well and take care of their weight, they would age slower. It was such an integral part. And as I started into my first practice, it was more geriatrics. I'm like, this is not for me. I really, really want to do preventative health. And so after that first year in private practice, I made that switch into really trying to hone in on, I think you even mentioned it earlier when we were kind of talking like 35 to 65 is
Yes.
that range where we can do so much. And I noticed that I had more and more opportunities to learn more and more about obesity medicine specifically. So I got my second board certification in 2013 in obesity medicine after really kind of doing it for 3 or 4 years prior to that, but not knowing that there was an actual like certification I could go and do.
Yeah, that's something for me too. Obviously, I've met a few doctors who are certified, but I would say as a medical doctor, I didn't really realize all that's available. What does that training look like? Like, what kinds of areas did you really learn as far as conventionally training?
Yeah, so my conventional, so I'm a DO, doctor of osteopathic medicine. So we had some nutrition during that time, but I will tell you, not enough.
Right. Same with
Um,
me.
and then I did an allopathic residency, so
Oh,
and
even less, right? That's
even
what I
less.
did. Yeah.
Yeah, so I had to seek it out. So very young, because I was really interested in wound care and hyperbaric medicine. I was lucky to start going to some nutrition classes and sitting with some of the nutritionists and figuring that part out. And with doing medical aesthetics as well. And so then, as I had an opportunity because I was the chair of pharmacy and therapeutics for a major hospital group here, I started learning even more. And they were starting a bariatric program, and they said, "Okay, can you do the outpatient side of this, where we have to follow them for 3 to 6 months before they can have bariatric surgery?" So it just became something that I was really honing in on and understanding. And then I had the opportunity to really train under some incredible obesity medicine specialists. And they said, "We'll train you and you can get your board certification." And so I did that. And like it's just kind of rolled, and in the beginning, I saw how hormones were important, but I trained in that 2002 to 2005 era where it was like, yay, hormones. And it was like, no,
Right,
stop it
right,
all.
right.
And I thought, oh, how am I going to help my patients here? Because there's like this black box warning. And so, yeah, it's like, and I think I think I can speak for you as well with following you. It's really important that we follow the importance of where medicine is going
Yes.
and always learn, because if we only took for what we came out of residency with, we're going to be behind the eight ball. Medicine is ever changing. And so I'm thankful that I kept seeking out either functional medicine or integrative medicine courses, because otherwise, if I was just going to the regular courses, I wouldn't be where I'm at right now or being able to really efficiently help my patients.
Okay, so you and I are totally the same as far as the allopathic residency, no nutrition, and then like 2001 when I graduated, and then residency up to '03, I think, or after. No, it was actually '03 to '06. So anyway, very similar time frame. And I think many who've listened to me before, we've talked about this, but I want to reiterate, when we get out in that time frame, when the Women's Health Initiative 2001, which is the year I graduated, it was so fascinating because, or actually the year I had breast cancer, I graduated 2 years later. Anyway, they really put the fear of God in us about hormones, and it was all false interpretation of the data, which you can
Yes.
talk to today about. But I love bringing this information because I'm still shocked as I talk to women about hormone replacement in a very healthy, supportive way, and the decreased risk of brain issues and bone issues and heart issues and even breast cancer in some cases, which people are terrified
Yes.
of. I'm still shocked at how many other doctors tell them, oh my gosh, why are you on hormones, right? So
Yes.
maybe let's set the framework with just the power of hormones used appropriately, because you are an expert there. And also, how do we really bring this message to women so that there's not the fear that happened because of that study and because of the data that wasn't even statistically significant, right?
Yeah, I'm just so excited really that the writers of the WHI, that they started to retract saying, "Oh my gosh, I think we are doing harm." And that started 2017,
Yeah.
2018. But again, like so many OBGYNs especially and our colleagues are
Yes.
a little bit behind if they're not going to some of the updated courses or really looking at it. So I'm glad that there are people like you and I that we are telling our patients, look, there are great books out there.
Yeah.
Like one of my favorites is Estrogen Matters by Dr. Bill.
Yes, I have it on my bedside. Like, I love it. And it's written by an oncologist. So,
Unpolished. I'm like, it's a breast oncologist. So,
yeah.
I mean, he goes
Yeah.
through all the
Yes.
literature over the last 20 years or more, 30 years, 40
Mhm.
years, and so it's so important that we really push them looking at the new evidence showing that one, the arm that had the increase in breast cancer they were on progestin. It's
Right.
synthetic progesterone, completely different than micronized progesterone. And then the estrogen arm that continued, they actually have less Alzheimer's, less cardiovascular disease, less breast cancer. No, like finally we're talking about it. So I love that you brought it up, and I educate my patients all the time. I'm like, I'm not the only one
Yeah.
who's saying this. Like you really need to do, these are safe places. I give them 5 or 6 different books, podcasts, or webinars. I'm like, and then the oh, what is it? PBS special came out.
Yes.
And that was so wonderful to see all of that being discussed.
Oh gosh, I love that so much. And again, because we were kind of brainwashed in a way. The data wasn't
We
holding.
were.
But when we got out of med school, we were both in that, like we were afraid because we were basically made to fear it because the data wasn't properly interpreted. But I remember years ago, as a breast cancer survivor, I would still say, gosh, if I had to choose my breast or my brain, I would choose my brain. And then I'm like, now I don't have to choose, right?
Don't, no. And
Yeah.
I love how internationally so much is written about with using hormones. I know several countries, even if you're a breast cancer survival, they want
Yes.
you on vaginal estrogen to reduce your chances of urinary tract
Yes.
infections, to help your pelvic floor function, because they know that importance and everything. So unfortunately, the US can be a little bit behind the eight ball there.
Right, right. Yeah, I couldn't agree more. So that's why I get so excited about you and any guest that we get to talk about this because women need this information, and I'm a big proponent. I know you are. So let's talk about the landscape of obesity medicine. You've been in this a long time, and you started in bariatric, which is obviously surgical, and now there's so many more options. But what changes have you seen, and along the way, like give us a little bit of the landscape of how people maybe used to have to approach weight loss, and now the tools that we have.
Yeah, the landscape has really changed in the last 5 to 6 years. But those of us who are trained in obesity medicine, we understand that we have a really big tool belt. There are so many, we call them AOMs or anti-obesity medications. And so we have about maybe 10 still on the market, but in the last 5 to 6 years, the really key components where most of your listeners will know about is semaglutide, which is Ozempic or Wegovy, or tirzepatide, which is Mounjaro or Zepbound. Those two really have changed the landscape tremendously. And it's good for those of us who are trained in this manner to know that we can combine medications, we can reduce medications. We really understand that it's not one size fits all, and we don't have to pigeonhole the patient into one specific medication. And I think that in the last 12 to 13 years, I've really seen that where I kind of knew what my starting medications were. It was like phentermine and which is still around. It's
Yeah.
been around since
Uh-huh.
1959, and I still prescribed it. I probably prescribed it 3 times today, because there's no withdrawal, there's no addiction. Like it's a great cheap medication still, and it's a great adjunct to if we're using injectables too. So maybe we can use less medication on with the injectable, so there's not as many side effects. But the landscape has definitely changed. More and more people are wanting to get into obesity medicine, and my fear is for the wrong reasons because they just want to be able to prescribe the medication, but they're not understanding the powerful tool they have, and that they don't have to use high doses to have results.
Okay, I couldn't agree more. I can't wait to dive into that. What I want to do is first talk about, and I think you and I will agree, a lot of times these GLP-1s, they work well, and many physicians who don't really understand are just giving the brand name at higher doses. And I feel like you do that there may be a better place, especially for people who don't have a huge amount of weight loss, where it's being overprescribed or overused. And yet, I feel like they're amazing drugs and so powerful when used right. Do you want to talk about the differences of like safe use, not safe use, where maybe the landscape is headed that may not be the best thing for these drugs?
Yeah, I mean, we could spend more than
A
an
whole lot,
hour
I know.
through this.
And then
So,
we'll go, just so you guys know, we're going to go into hormones and metabolic because I really want to talk about that, but for the moment.
well, with the GLP-1s and the combo, GIP, GLP, which is the tirzepatide, it's incredible. And so many times we can start low dose. And unfortunately, the only pen that's adjustable is the Ozempic pen, and that's specifically for diabetes. And I love that it was adjustable because then we could start super low and sometimes keep it low. With the others, the Wegovy, Mounjaro, and Zepbound, it's a one dose pen. And I think that's really where we got in so much trouble with it. They're now, making it in vials so that it's a little bit easier. But I mean, let's be honest here. I was doing it compounded for my patients for the last 2 to 3 years. I was being very specific on where I was obtaining it for my patients because I wanted it correctly done. Um, I didn't want to see cellulitis. I didn't want to see, because of how it wasn't being manufactured properly. So the pharmacies I chose were very methodical on where they got the medication from and how they were preparing it for our patients. What I loved about that is I could one microdose it. So a lot of people say microdosing, they don't understand it. Microdosing are the smaller doses that are available. So let's say 0.25 on semaglutide is the typical starting dose, but I can start it at 0.07,
Yes.
0075 or 0.01.
Yes.
That's microdosing. And we don't have to go up to the higher doses. If my patient came back and said, I'm not hungry, I don't have food noise, and I'm safely losing weight, why would I go up? And then I also notice they're less inflamed. They're not carrying around as much water intake. And now we're seeing, the literature even say that we can use this for anti-inflammatory type of processes.
Hey guys, just a really quick 10-second interruption to let you know if you haven't yet got the book, Unexpected, you can get this at readunexpected.com. Best-selling Amazon, you can find it anywhere where books are sold. And I promise you it's going to be an inspiring journey to check that out. You can find it at readunexpected.com or anywhere books are sold. Okay, back to our show. I completely agree. And I've been using that very frequently. And what I see, I deal with a lot of mast cell activation and
Yes.
really complex chronic illness. And there is a clear, again, this is my clinical experience, but I think the literature will support this in time, that there is a very clear anti-inflammatory benefit in some of these patients. That, I mean, some of the time in the very beginning, they would even come back to me and be like, yeah, the weight loss is great, but here's what I noticed, right? My brain's better, my joints feel better, less pain, less inflammation. And then I started diving in and realizing, just like you said, there's actually so much more benefit. And just like you, I want them on the lowest dose, the shortest time to have the effect. And then that microdosing really works well.
Yeah, I would love to do like I've invited anyone. I'm like, one, I want to prove that my patients don't have sarcopenia,
Right.
that they, that I can even dose it out where maybe it's every 10 to 14 days once we get to their goal. Like we just don't have the research to say that, but so many of us in this field are doing that.
Yeah.
And then in the past, I've been doing some past research too. There are a few papers that are published talking about reducing cytokines and inflammatory, like our interleukins and our TN. So there is information even from the older generation GLPs that are out there showing the anti-inflammatory like response of this class of medications. So it's really interesting. I think the field is it's going to be wide open. I mean, I don't know, is there like 5 or 6 more coming out in the next 3 to 4 years?
Yes. Yes.
So
And
we'll
and
be able to see
good
that.
or bad, the fact that the pharmaceuticals are making so much money on that is leading to more research. I don't love that, when they like take over the market and it's all
I
about
agree with
money.
that.
But in the realm for our sake as clinicians, I think we will have lots of good research on these other benefits, which is exciting. Now, your thing is hormones too. You really understand, and obviously the HPA axis, the female and male hormones, and the thyroid all have such to do with. Do you want to give us a little primer? You could probably spend 2 hours, but maybe just a little glimpse, because like I said, most of my listeners, men and women, but the age range is kind of this time when the hormones do fluctuate. How does that affect weight, and what would people like to know more about?
I think most of us, when we enter into perimenopause, we don't like to hear, oh, it's just part of getting older, it's a rite of passage. It's not. There are so many things that we can do, and I don't like when especially women, are poo-pooed. As soon as the male's testosterone starts to drop, it's like, which form of testosterone do you want?
Right.
And with us as women, one, they're scared of hormones, as we kind of opened up talking about. And two, they're not really understanding that we can start treating this perimenopausal state and replacing, our hormones earlier than when we classically go through. No, you haven't had a period for 1 year. You're menopause now. Here's your patch.
Mm-hmm.
And our metabolism does change. That decrease in estrogen really makes a difference on how we place our how our visceral fat starts to get a little bigger. I mean, what woman says, says, I never had a pooch. Now I
Yes.
have a pooch. I'm not being able to, my endurance working out is not the same. I can't build muscle like before. And that, we'll check their testosterone. It's literally zero.
0.
And I love to tell women our ovaries and our adrenal glands produce testosterone. Like it's
Yeah.
not a male hormone, it's also a female hormone. And you also brought up our thyroid. I think as we age, we're more likely, and the conditions that we're living in, our thyroids are not working as well. And it is part of that. It is when we balance the thyroid, sometimes, our estrogen and our testosterone, all of those are a little bit better. There's this balancing. So just to check one aspect is not enough. We really need to follow that HPA axis, like you mentioned, and really dive into it because as we get healthier, let's say someone is having their glass of wine, they're eating lots of carbs, they're actually working out too much,
Yes.
and they're just fatigued. They might need more hormonal support until they start to change their lifestyle. And then we can kind of back down on some of that hormonal support because their ovaries wake up where they'll go, oh, I was going every 3 to 4 months. Now I'm back to monthly. Is that bad? I'm like, no, you're reversing the aging process.
I love that you mentioned that because for me, when I hit 40, so I had cancer in my 20s, and so the chemo hit my ovaries, and then I had celiac and amenorrhea for a while, and all that just to say that my poor ovaries, I'm so happy they made it to 40 because it's kind of a miracle with all that they got hit with way early in my life. And I think I hit menopause around 44 or 45, so a little early. But what I wanted to share, and I'd love your comment on this, is before that, before the age of 40, I was doing high intensity interval running at a pretty fast clip and really pushing myself, usually getting up in the morning, going to do an intense workout, maybe 5, 6 days a week. And I always carried just a little extra. I mean, I was fine and healthy, right? But for me, I always felt like I had a little superficial weight, just maybe 5, 10 pounds. And when I hit 40 and actually stopped working out, I always joke about I got in the best shape of my life because, as you mentioned, as you can totally see what was happening, right? I was driving that cortisol up. I was estrogen dominant. And so both of those things together, cortisol, way too much estrogen related to like zero progesterone, was just the perfect storm. And then when I started slowing down, walking, doing some weight training, and doing a lot less high intensity cardio, I got in such better shape, lost, 5 or 10 pounds, and I've just stayed there, super healthy, strong. But then what happened is I met a trainer recently. I've been working with him, and now I'm running again, but I'm doing it totally different. I'm keeping my heart rate in zone 2. My body composition is best it's ever been, but it's so interesting. I love your comment because I think my experience may not be so different from the women out there where I was totally over exercising, especially with a stressful life, right?
Yeah, I love that you brought it out because mine, I love to say my ovaries gave me their all until about 45 or
Yeah.
46.
They're
And
like, oh, we're done. We're out.
yeah, and that was the same thing. My acupuncturist at the time, she looked at me and she's like, Melody, you need to stop going to boot camp. I'm like, I looked at her like, you're crazy.
Exactly.
My stress relief, I love it. My 5 a.m. group is my
Yeah.
my crew. Like,
Right.
what do
Right.
you mean? She's like, you have no reserve right now.
Yeah.
And I'm telling you, you're not allowed to go. And I'm just like, you can't tell me that. But I'm
Right.
so thankful that she did because I started yoga at that time
Mhm.
and I started to train differently.
Yeah.
And I've had a trainer now for the last 3 years. I've never had this much muscle in my life. And I have not returned to boot camp. I just do it. How I work out is completely different than 5 or 6 years ago. But I'm so thankful that someone had the gall to say it to me because I think a lot of times they don't want to tell us things. They're like, "Oh, she's a doctor, she'll get
Right.
it." But she was like, "No, you are doing damage right now." And whenever, like, think about it, all of our patients, when I tell them that, I need you to slow down. We're going to have to change your workout routine. They have that same, oh my gosh, I'm going to gain all this weight.
Yeah.
What are you telling me? You're taking away my lifeline. And I'm just like, give it 3 months. These are the things I want you to do. We're going to try yoga or Pilates or like just walking instead of running. And then 99% of the time, they're coming back and like, I didn't believe you, but I'm so glad I trusted you. We're just used, especially our generation, we're used to like at the gym, pumping it as hard as possible. And like you want to come home and crash on that couch.
Yeah.
And we didn't realize what we're doing to our adrenals. Yeah.
I so love that we have such similar stories because I think a lot of our listeners are professional women or women who have, raised a family, do the work, do all these things just like you and I. And it's funny because medicine by nature kind of trains us that way, right? You push you hard. It's a very masculine driven kind of thing. And I love that we're having this discussion because I think the biggest thing, my biggest aha was I am a physician. I know like functional medicine well. I've been doing it 20 years. So are you. And for us to not have that knowledge about over exercising and the cortisol, I mean, we know the HPA axis. This wasn't anything foreign to us, and yet I was doing it all wrong. So, first of all, that's just a big aha because I think if you and I, as professionals who are in medicine, didn't really understand that, how much more is the average person not getting that message?
Right.
So how do you frame if someone comes in and say let's say it's a 45-year-old woman, they're in perimenopause or menopause, and they're struggling with an extra 20 or 30 pounds. And do you do it every person individual? What would you do for a workup? And then what would you recommend they do as far as their exercise routine and diet?
Yeah, so my consultation is a whole hour, and they fill out probably 6 pages on their history before they see me. And then I decide on what lab panel to get because that, in my experience, makes it a much better consultation and I can give a direction much easier. But I like to know how many kids do they have? Are they already raising grandkids? What is their work-life balance? It makes such a difference to know that about them. What does their nutrition look like? And I do more than just a TSH. It's so important for them to know their whole thyroid panel and thyroid antibodies. Women especially are prone to Hashimoto's, which is, autoimmune thyroid disease. And a lot of times when we find out, I mean, you have celiac,
Yeah.
we understand that our diet can really affect how our thyroid functions. And so I'll look at that. I'll look at not just an LH or an FSH. It's really important to get their estradiol level, their progesterone level, like their DHEA. There's so many more hormones than just what in med school we were
Yeah.
taught, or when someone was thinking about conceiving, the only little tiny,
Uh-huh.
hormone panel that we did. A morning cortisol can be very helpful, a morning insulin, and A1C. So many people don't understand what their risk factor for insulin resistance is. So they probably, I love it. Most of my patients are like, oh my gosh, I've never had 6 to 8 vials,
Right.
removed at one time. But I'm looking at the whole picture because that then lets us know what can we tackle? What are we going to tackle as far as your sleep wake cycle, your exercise cycle, your stress reduction? What hormones do we need to replace maybe right now? What do we need to go on thyroid? There's so many. If you're a pre-diabetic, I
Yeah.
don't wait till you're a diabetic. If you're showing insulin resistance, we're going to talk now. We're not going to wait, until your A1C is at 6.5. That's not fair. That we are really teaching incorrectly on that. How about when the A1C is 5.4, 5.5, 5.6? We start having that discussion going, you're on the road for prediabetes and diabetes right now. Cholesterol, our triglycerides tell us so much. Do an extended lipid panel. It's more than just total cholesterol, triglycerides, HDL, and LDL. Like, do you have genetic markers like your ApoB or your lipoprotein A? Like, what's your CRP? There's so many important labs. And that gives our patients, especially mine, I want them to have the tools that they can then follow and the numbers to follow to see how their body is responding to them getting healthier.
Oh my goodness, you and I are just very similar in the approach. I think that's so powerful. And women and men want to, you see both men and women?
I do, and I love it because when the females do, like usually they'll be like, "I'm dragging my husband in here,"
Exactly. Or even my son or daughter. It's like the whole family comes once they
I
find
do. I
the
love
power.
it.
Oh, that's
I
so
love
great.
it.
We'll finish on women and then we'll talk a little bit about men because that's an important thing too. And I always find that in some ways that's simpler because there's less hormones to deal with, but they still benefit from all of these same exact things that you talked about, including estrogen, right? For men, we want to make
Do.
sure it's not too high. So for the woman who, metabolically is maybe pre-diabetic, say their A1C is 5.7 and their insulin's like, 15, fasting, where would you start with someone who is metabolically out of shape and with the weight loss picture? Give me kind of just maybe the top 3 to 5 things that you would say these are really key for when you want to reverse a pre-diabetic.
Yeah, one would be reducing carbohydrates, simple carbohydrates, processed foods. If they're perimenopausal, I'm going to tell them not to fast right now. I'm
Mhm.
going to tell them they need protein at least 3 times a day. And I'm with Dr. Lyon. I want 1 to 1.5 grams of protein per kilogram body weight. And maybe we just shoot for 3 times a day. But when they're in that state, I want a routine. I don't want fasting yet. When I see that they have reserve again, we'll talk about intermittent fasting, but I take them away from that. I also remove soda. That's
Uh-huh.
not their friend. I remove alcohol for a while. They really cringe because I don't know why perimenopause and menopausal women love their alcohol, but I'm
Yes.
like, we're taking it away for a little bit.
Uh-huh.
It's empty calories and it really slows down your metabolism and it has poor sleep.
Mhm.
um, that's another topic. I'll tell them get a Whoop, get an Aura ring, watch what happens when you drink alcohol and everything. Um, and nutrition, I guess, would be one. Two would be if they're really interested, I still love berberine. Um,
Mhm.
and then depending on other risk factors or where their body fat percent might be, we might introduce a GLP-1 at this time and it might be more microdosing
Yes.
at this. I'm still, if someone has that history of PCOS, or if there is a monetary constraint, I still love metformin. Metformin is incredible especially if they don't want to do maybe berberine at higher doses, therapeutic doses. So I start thinking about that, and then sleep. I want to really dive into their sleep routine because that's where restoration happens. That's where insulin and cortisol levels come down. So if they're not sleeping, whatever I do is not going to stick, and we'll be banging our head against the wall. So I think those are my top 3 things that I really will dive into at first.
Love this and so practical. Agree 100%. Now let's shift to someone may or may not be metabolic. We've really covered that, but say we have this perimenopausal woman who's starting to have irregular cycles. Maybe she's gone 3, 4 months at a time without a cycle. She's starting to have trouble sleeping, maybe a few hot flashes. Walk us through how the hormones might affect weight loss and obviously your checking number. So right now we're going based on not having the labs, which you would have, but
Right.
maybe just so someone's listening saying, oh, I'm 39 and having symptoms, or I'm 55 and having symptoms. What would you do if weight loss was a primary concern with hormones in that range? And you can give us a variety of situations.
Oh yeah. So I might start off with just progesterone and testosterone because testosterone, as it gets converted, it'll actually help increase their estradiol. So, while they're still cycling, we might really not talk about estradiol just yet unless they really are having horrible hot flashes and mood swings and really pushing into it. But I love starting with low dose progesterone, micronized progesterone, because we go back to one of those key topics of sleep. It really does
Yes.
help their sleep and their mood. We might cycle it, we might change it depending on if they're really PMSing still, so they might not stay on the same dose through the month. And then I'm a fan of testosterone. I really am. Smaller doses, they don't need to be on higher doses. It saved me. It was the first thing that I went on, and it was amazing. And I love to share my story with my patients because they just look at me like, really? And I'm
Really?
like, yeah, yeah. My endurance, my libido, I know it helped with shedding some of that belly that I was just like, what is this? It really helped, I feel like, my metabolism out. So I talk to them about probably progesterone, and either testosterone or DHEA. Some who are really nervous about testosterone at first, I'll go on I'll put them on DHEA, because again, if we kind of roll back, it's that precursor to that testosterone. So that's kind of usually where I will start with someone who's wanting to do hormone therapy. But again, their thyroid ties into this. Are they borderline? So someone who's having those symptoms of hair loss, dry skin, constipation, cold hands and cold feet, classic thyroid. Like classic. No, and these are my women who are like, I want to put socks on when I go to sleep.
Yes.
I'm sitting on my hands,
Yeah.
and they'll have a TSH that still might be in range,
Right.
but optimal is probably 0.5 to 1.5 for a TSH. Free T3, if it's not above 3.4, I mean, it's really not. They're struggling, and when they have all those symptoms, we're going to go on a low dose thyroid. And guess what? And this is goes to back what I talked about, that their thyroid might recover. They might not need it long term, but I'm going to support it until things are better. So when their energy, their concentration, they're starting to shed some of that weight, they're able to make more changes in their lifestyle because they feel better, So
Oh goodness, I could not agree more. As always, it's so good because I think women just need to hear that. The testosterone is so important. What I have realized, so obviously I had breast cancer at 25, so I was leery because of the false interpretation of data in my late 20s and 30s about hormones, and then of course we got the full story. But as a breast cancer survivor, I've had a particular interest. And in the 1940s, they used testosterone to treat breast cancer. And when I dove into the data, and there's actually a new company coming out that is actually using, this is new research that will be being published. They're using testosterone with aromatase to treat DCIS, and the preliminary studies are phenomenal. And the reason is this actually blocks the estrogen receptor to some extent. And I remember reading some of this. So when I first started having symptoms, that was exactly what I did, was progesterone and testosterone, and found it so powerful. And again, now I get to talk to patients about the power. And now, again, it's just phenomenal to me that it actually could be protective or preventative, or even as this data comes out, maybe helping to treat breast cancer. Now, again, don't go by my word. The research is coming out, but I really feel strongly that it's a powerful part of women's hormone replacement and optimal body composition, like you. And so, love that you're talking about that.
I love that you brought that up too, because even my breast cancer survivors, I will call their oncologist and I will say, look, I'm not, depending on, we'll go through it. Is it ER/PR positive? Is
Right,
it
correct.
genetic? But I'm always like, the first thing I'm like, can we do testosterone in low doses? I need to get their muscle mass back up. Like, I need to help with some of their symptoms. And I love that there are a few that have been on top of the research as well, that they're like, yes, and I will follow along with you, because they're more at risk for osteoporosis and sarcopenia and Alzheimer's, and so much. So if we can start with a little bit of testosterone therapy to give them back a little bit of their health, I get ecstatic and happy and just like want to do a flip for them.
Oh, I agree with you. And same exact conversations going, do you realize how safe this is at the appropriate doses and everything? Because, like you said, when you have a patient who's been through cancer and they're sarcopenic and they're losing bone, they're at more risk of dying from a hip fracture. And so we
Yes.
need to really, like, I mean, we have to uh, be very much of an advocate for them because these other things are so important. And sometimes I know so many amazing oncologists, but there's a few that are so focused on this one marker of the cancer and they're not thinking about the quality of life. I just think it's a tragedy for those patients.
I do too, especially when I get the ones, and I love my oncology friends. Their whole goal is help you survive. I mean, I know that when you're 25 and you're
Right.
faced with that, you're like, just help me survive.
Right.
I'll figure out everything else.
Right.
But once they have survived, it's like, how do we help them thrive? How
Yeah.
do we keep them from having that fear anymore? Like, we need to stop having fear and helping them thrive,
Yeah.
because so many oncologists will be like, you just have to deal with the symptoms for the rest of your life. You're going to stay on this. And I'm like, that I have so many women who will tell me, I would rather have my brain than my breasts, as
Yes.
you
Yes.
mentioned.
Exactly.
I would rather take off 5 years if it meant I had better 5 years where I wasn't dealing with all these side effects of the continued therapy. So
Yeah.
I feel like in medicine, unfortunately, we have lost the touch of having that conversation where we just look at a diagnosis and give a treatment and we're done.
Right.
I want to go back to that old school where we have a conversation. We encourage the patient to make a decision with us, and we talk through the risks and the benefits of each decision that we make. And we continue, not say, I'll see you in a year, but we have adequate follow up so we can pivot every time we see each other if needed.
Yeah. Oh, I love that. So true. We have covered a lot. Is there anything else in relation to hormones and weight loss that you feel like maybe people will need to know that we haven't really covered? Either.
Yes.
Yeah.
when you turn 65, stay on your hormones. Do not let them stop your hormones.
Oh, yes, yes, yes. I'm like your biggest cheerleader, Dr. Melody, because everything you say, I'm like just nodding and going, oh my goodness, amen. This is so great. I totally agree. It's interesting because I worked with Dale Bredesen, who just deals with Alzheimer's and teaches Recode, and some of the doctors who treat that. I mean, he's starting women at 85 on estrogen because of the brain. And so, and again, there's controversy there as far as how you do it and watching it and receptors that, what happens often is if we've never had hormones in our bodies, the receptors kind of shrink up. And so there's this whole mechanism there. But the truth is, for the brain, there is zero question about how much our brains need estrogen.
Yes.
So,
Yes, I totally agree. So I just wanted to get it out there because I
yeah,
know someone who's listening has been
yeah,
like, they're going to take me off
yeah.
my hormones because I'm turning 65. I'm like, no,
No,
we
no.
can safely stay on it as long as we want. And I love because that storyline is changing too now, finally. But so many are going to practitioners who are still old school. So I
Yes.
wanted them to hear it here and know that they can continue safely on their hormone therapy.
Totally agree. And I'm so glad you said that. This has been one of the most power packed as far as just really good information for our listeners. And I'm so grateful. And you just have such a beautiful joy and how like you come across so lovely. I want to just give you a big hug.
I know I feel like we need to be friends now.
I
This is
know, right?
great.
I'm the same way. Like, let's go have coffee. But tell people if they want to know more about your clinic, about what you're doing, any resources, where can people find more about you?
Yeah, so I'm in Arizona, in Gilbert, Arizona, a little suburb. My practice is called Activated Health and Wellness. And we do see men too. So I think a lot of people don't know if we see men or not. And we are a cash pay concierge. And that's because I want to do what's right for the patient and not what the insurance company is telling me. And I want to have a 30, 60-minute appointment with my patient, not a 10-minute appointment. So I have several providers who work with me, and we do weight loss, we do hormone replacement, we do personalized medicine. It's definitely my forte, and I really, until the day I die, want to continue doing this and just advocating for our fellow colleagues to teach them that there's so much more out there if they haven't done that extra that extra training, and two, for our patients to really seek out the care that they deserve, because they do need to have practitioners, providers that are willing to listen and know that it's okay if you don't, if you're, you can't fit in the box. Anyway, that can go on and on, but thank
Yeah, I
you.
agree. But thank you for sharing. And if you guys are listening, wherever you're listening, in the show notes, we'll have resources and links to Dr. Rodarte. But most of all, just thank you, my friend. It's been an absolute pleasure to interview today. And thanks for the amazing work you're doing at helping to people to heal in menopause and beyond, right?
Thank you. Thank you for all the work that you do.
Hey everybody, wasn't that a great interview? I just love her energy, and I can see her as being next door and us having coffee. Such a sweet person and beautiful, brilliant physician. So I hope you enjoyed the interview. I hope it was practical. Please leave comments, questions below. I come in, pop in, and answer those. And if you are not yet a subscriber on YouTube, join me. I think we have over 600,000 subscribers at the time this is recorded. Go ahead and click that, click the bell to be notified of future episodes. And we will see you again next week on another episode of Resiliency Radio.